And our first speaker in that regard is Bill Karnes from UCI, professor of medicine and head of the colorectal cancer research program there. And Bill is going to go through some abstracts from this year's DDW. Come on up.
Well, thank you. Hello, everybody. So I'm going to be describing 4 abstracts that I found particularly interesting. Let's see it forward. Okay, this is my disclosure. I'm co-founder of DocBot and CMO. So the first abstract is the impact of serrated polyp detection during the first surveillance exam on the outcomes in the second surveillance exam. And the reason this is important is the task force, the United States Multi-Society Task Force recommendations for surveillance after its initial screening exam took into account all of these different kinds of polyps, the number of polyps, the type of polyps, and the size of those polyps to guide us in determining when a patient should come back. And but the unfortunate thing is that it doesn't include their guidelines for the second surveillance. So the first surveillance, they come back, let's say 3, 5, 10, or 10 years. Then you do another scope. What do you find this time? And when should they come back now, taking into account the initial exam and the subsequent exam? And the guidelines for that are shown on this slide. They don't include any of the serrated polyps, only adenomas. So this group sought to assess whether there was a significant increased risk for colorectal cancer, advanced adenomas, or serrated polyps larger than a centimeter on the second surveillance in those who on the first surveillance didn't have adenomas but did have a clinically significant serrated polyp. And they defined clinically significant serrated polyps as any sessile serrated polyp, any traditional serrated polyp, any hyperplastic polyp greater than a centimeter in size. And they also include this other group of hyperplastic polyps that are actually greater than 5 millimeters, but proximal to the sigmoid. And previous studies by Anderson and others have shown that these predict metachronous advanced lesions. So this is the way their study looked. They had about 3,000 patients to start with who had a first and a second surveillance exam to study, and those were at least 12 months apart. And they excluded all of those who were high risk, who had high risk lesions, genetic syndromes, et cetera. And what they found, what they did is they looked at the results of the first, let's see, do I have a mouse? Yeah, great. They looked at the results of the first surveillance colonoscopy, eliminated all of those that had advanced lesions, and then only looked at those who did or did not have low-risk adenomas. Of those who had no adenomas, they took that group and looked to see which of them had clinically significant serrated polyps, and then just simply asked the question, does the presence or absence of these sessile or these clinically significant serrated polyps predict what you're going to find on the second surveillance? And they found a significant increase in the risk of advanced adenomas, colorectal cancer, and serrated polyps in this group. So their conclusion is the task force should consider providing interval recommendations for exams with clinically significant serrated polyps detected on this first surveillance. The next abstract is titled "The Differences in Adenoma Detection Rates and Other Indices Between Standard Screening Colonoscopy, Computer-Aided Detection Colonoscopy, and Endocuff device, and then also in combination." This is actually the first time anybody's looked to see whether a combination of CAD-E and Endocuff would actually further impact the detection rate of polyps. So we all know that computer-aided detection on many, many papers has shown that there is an increase in adenoma detection, as well as with Endocuff. There's a lot of papers that show the same thing. And so their aim was to compare these. They had 4 arms, either CAD-E alone, the Endocuff alone, or the combination versus standard colonoscopy. They all used the same high definition Fujifilm scopes, and their primary outcome was ADR. And then the secondary outcomes were the proximal ADR, the number of adenomas per colonoscopy, and the number of proximal adenomas per colonoscopy. The group was well balanced. And here's a summary of their results. What they found was that endocuff alone, or in combination with the computer-aided detection, that was associated with a significantly improved rate of detection of adenomas, proximal adenomas, and then the number of adenomas per procedure, as well as proximal adenomas per procedure. Whereas CAD-E alone was only good for the number of adenomas per procedure, both overall and proximal. So the next abstract is, which one I find particularly interesting, is the idea of diagnosing polyps in situ during colonoscopy to allow us to perhaps do what Doug Rex really wants us to do, which is to leave them alone or resect and discard. And so having an artificial intelligence module that can reliably tell us what a polyp is potentially could allow us to save a lot of money. So this leave-in-situ, according to PV thresholds, applies to under 5 millimeter polyps in the rectosigmoid. And if the test that you have that allows you to diagnose that polyp has a negative predictive value of 90% or greater for adenomas, then you can't just look at them, and if it says it's not an adenoma, leave it alone. Resect and discard, on the other hand, applies to less than 5 millimeter polyps located proximal to the sigmoid. And what this requires is a greater than 90% concordance in what you're going to tell the patient in terms of when they need to come back for their surveillance exam. So the tool they're using is actually regulatory approved in Europe. It's a combination of a polyp detector and then a polyp characterizer. And the unique thing about it is it doesn't require MBI, it doesn't require magnification. It can be used with any conventional scope. And then what they did is they just applied this tool to consecutive patients who are undergoing colonoscopies in a nationwide colorectal screening program. And for each polyp, the CAD-X output was compared to the gold standard, which was the histology that the pathologist rendered. And then they just looked at those two important outcomes for resect and discard and leave alone, which is the negative predictive value for adenomas and then the concordance of surveillance interval. And this is what the output looks like, the green box for detection, and then under the box, a description of what the prediction is for the polyp itself. And the potential ones are adenoma, non-adenoma, or in some cases, it can't predict what the pathology is. Oh, it's not moving forward. There we go. So in their results, I'll just summarize this very quickly, but they had 162 consecutive patients. There were 130 patients with at least one polyp, and 494 polyps that were 5 millimeters or less. And of this group, we can see that within the rectosigmoid, the negative predictive value for adenomas was 97.6%, which is well above the threshold for leave alone. And for the concordance with surveillance interval, the concordance was 95.6%, which is well above the 90% threshold. So this certainly suggests that this device potentially could be used for leave alone and resect and discard with potentially millions of dollars in savings in pathology costs. I think this may be the last one. This multimodal blood-based colorectal cancer screening is a viable colorectal cancer screening option. This is the first prospective study of this blood-based test for colon cancer screening. As we know, about a third of patients don't follow through on colon cancer screening, and those that do, maybe even up to 50% in the VA, may not even come in for their colonoscopy. But one of the key things is, what about this 30% who aren't following through with screening? If we had a blood-based test that was equivalent to a FIT or a Cologuard, wouldn't that be, I would expect, a much better uptake. So this was a retrospective study of this multimodal blood test-based test. Previously, they had just done this test on people with cancer and found very, very high specificities or sensitivities. No prospective studies have yet been done, and that was their aim. So what they did is they took patients undergoing procedures in Spain. Blood was drawn at the time of the procedure, and the results were integrated. And what they did is they had the test, they defined either a 90% specificity or a 95% specificity, and then looked to see what their sensitivities were. 557 subjects. There were a variety of indications here, so this is not the kind of study where it's going to validate its use in screening colonoscopy, because only 33% were average risk screening. Overall, in this study, only 8 cancers were found, and that's what this study is all about, looking at these 8 cancers and what the sensitivity and specificity was. So this is their data with specificity cutoff of 90%. The overall sensitivity was 100%, 8 out of 8, and at 95%. The only outlier here was they missed one stage 2 cancer. So this is a very preliminary piece of data, but it's kind of promising for the large prospective study that they have currently going for screening. And we're waiting for that. And that's it for my session.